Neonatal Care Part 2, APGAR scoring, neonatal resuscitation practices, and specific interventions. The APGAR score. So the APGAR score helps record the newborn's condition in the first few minutes after birth. It helps determine specific resuscitation measures needed and their effectiveness. Your categories: A, appearance, which would be skin color; P, pulse rate; G is grimace or irritability; A is activity or muscle tone; and R is respiration, the effort. Each sign is given a value of 0, 1, or 2, and is recorded at 1 minute and 5 minutes after birth. If the 5-minute score is less than 7, an additional score should be done every 5 minutes until 20 minutes after birth. If resuscitation is necessary, determine another APGAR score after resuscitation efforts are conducted. The neonatal resuscitation algorithm. Initial steps, reevaluation, and initiation of ventilation should occur within the first 60 seconds. This is going to be very important. Remember that our first steps in neonatal resuscitation occurs within the very first 60 seconds. Follow the initial steps, providing warmth, positioning the airway, clearing the airway of secretions if needed, drying and stimulating the newborn. If the newborn does not respond, further intervention is necessary. Assess the respiratory rate, respiratory effort, pulse rate, and color. Count the respiratory rate and pulse rate for 6 seconds and multiply by 10 to determine rate per minute. Many newborns have acrocyanosis, which is going to be bluing of the extremities, but are centrally pink. If there is a normal breathing pattern and pulse rate greater than 100 beats per minute, but maintain central cyanosis of the trunk or mucous membranes, provide supplemental free flow or blow-by oxygen. If still apneic or have a pulse rate of less than 100 beats per minute after 30 seconds of drying and stimulation, you should begin positive pressure ventilations by a newborn-sized bag mask device. So let me repeat that. If the patient is still apneic or has a pulse rate of less than 100 after the first 30 seconds of drying and stimulation, then we begin PPV. Be careful to not squeeze the bag too hard in order to avoid hyperinflation of the lungs. Room air is preferred when resuscitating term infants, and the addition of supplemental oxygen may not be necessary. Additional oxygen may be necessary if the neonate has not achieved the target preductal oxygen saturation value for their age. If the newborn's pulse rate is less than 100 beats per minute or they're apneic again, we're going to continue ventilations. If the newborn's pulse rate is less than 60 after we have ventilated the patient and we've went several rounds of ventilations, then we will begin chest compressions. Effective chest compressions should result in palpable pulses. Use a pulse oximeter when resuscitation is anticipated. The newborn appears cyanotic. PPV or chest compressions are needed. If ventilation and chest compressions do not improve the bradycardia, administer epinephrine, preferably via an IV line. You can also consider an IO route if IV access is not possible. When no signs of life are present after 10 minutes of resuscitation, the chances of successful resuscitation are very low, and overall outcomes are associated with high early mortality. This is the neonatal resuscitation algorithm. So if you notice, the first steps are within the first 1 minute. Birth. Is it a term gestation, good tone, breathing, or crying? If the answer is yes to any of these, then the infant will stay with the mother for routine care. We will continue to warm and maintain normal temperature. Make sure we position the airway, clear secretions if needed. If the answer is no to any of this box, we need to warm and maintain normal temperature, position the airway, clear secretions if needed, and dry and stimulate. Are they apneic or gasping, or is the heart rate below 100? If the answer is no, we need to check to see if labored breathing or persistent cyanosis is present. If so, we need to reposition the airway, monitor SpO2, and consider supplementary oxygen. If the answer is yes to apnea or gasping or heart rate below 100, we will begin positive pressure ventilations. So positive pressure ventilations in reality should begin within 30 seconds. We'll then reassess. Is the heart rate below 100? So if you notice this, if the heart rate's still below 100 after we reassess, we're going to check chest movement. We're going to try to do any corrective steps for our ventilation, and we're going to consider advanced airway. We have not begun compressions yet at this point. If the heart rate is below 60 per minute after we've done these steps, then we're going to intubate if not already done and continue chest compressions. If the heart rate still remains above 60, but the heart rate still below 100, we're just going to continue to ventilate and reposition. We're going to coordinate our PPV with chest compressions if we are doing compressions with 100% O2, continually monitor the ECG, and then we also may consider an emergency umbilical vascular catheter. If the heart rate is still below 60, even after rounds of chest compressions, then we will consider IV epinephrine. If the heart rate is persistently below 60, consider hypovolemia or other causes such as pneumothorax. Another thing that we need to look at will be the preductal SpO2 after birth. So a newborn's SpO2 may not be what we would consider as normal limits until after 10 minutes because it takes that long for the newborn to transition from the fetal stage to actually being born and for the circulation to continue through the body. Drying and stimulating. After ensuring the airway is patent dry, stimulate the newborn. Position the infant on the back or side with the neck in the sniffing position. Tactile stimulation, such as drying the newborn and flicking the soles of the feet, can be used to stimulate breathing if the newborn has ineffective breathing effort. Consider suctioning if positive pressure ventilation is needed and the airway appears obstructed. Free flow or blow-by oxygen. If the newborn is pale or cyanotic, provide oxygen. If positive pressure ventilation is not indicated, oxygen can be delivered via blow-by by an oxygen mask or even oxygen tubing. Oral airways are rarely used on newborns. There are certain conditions that may require oral airways. Bilateral choanal atresia, Pierre-Robinson sequence, macroglossia, or craniofacial defects that affect the airway. In all of these cases, except for bilateral choanal atresia, an ET tube is inserted down a nostril. With bilateral choanal atresia, bony or membranous obstruction of the back of the nose causes the inability to insert an ET tube through the nostril. The Pierre-Robin sequence is a series of developmental anomalies that include a small chin and a posteriorly positioned tongue. This is choanal atresia. So if you notice in a newborn with this, they have a bony blockage in the nasal passage, so you're unable to insert anything that way. The Pierre-Robin sequence is a set of abnormalities affecting the head and face, consisting of a small lower jaw, a tongue that is placed further back than normal, and blockage or obstruction of the airways. Most people with Pierre-Robin sequence are also born with an opening in the roof of the mouth, also known as a cleft palate. With bag mask ventilation, when this is indicated, you want to make sure that you're only delivering enough air so that the patient is getting bilateral chest rise. Devices that deliver bag mask ventilation. You got self-inflating bag with an oxygen reservoir. You got a flow inflating bag or a T-piece resuscitator. T-piece resuscitators are often used in the hospital. When administering bag mask ventilation with 100% oxygen, the face mask should provide an airtight seal. Airways should be patent and the head should be in the sniffing position. The first few breaths after birth frequently need higher pressures. Subsequent breaths should have enough pressure to deliver a visible but not excessive chest rise. A ventilation rate of 40 to 60 breaths per minute is important because a higher rate can cause hypocapnia, air trapping, or even pneumothorax. We'll continue positive pressure ventilation as the pulse rate is less than 100 beats per minute or the respiratory effort is ineffective. Intubation is indicated when meconium stained fluid is present and the newborn is not vigorous. Congenital diaphragmatic hernia is known and suspected. If there is a situation where you have prolonged positive pressure ventilation that's needed, or craniofacial anomalies impede an adequate airway. You should have the following equipment: suction, laryngoscope, blades, shoulder roll and adhesive tape, and an ET tube and stylet. Gastric decompression may be indicated if you have prolonged bag mass ventilation, abdominal distension is impeding ventilations, and diaphragmatic hernia or GI congenital anomaly is present. Chest compressions are indicated if the pulse rate remains at less than 60 beats per minute after resuscitation efforts. 2 people are needed for effective chest compressions. For 2 people, you should use the hands encircling thumbs technique. If just 1 person, you should use the 2-finger technique as shown here. You should compress to a depth of 1/3 the anterior-posterior diameter of the chest. And chest compressions and artificial ventilation should not be delivered simultaneously. Coordinate 90 compressions and 30 breaths, equaling 120 events per minute. Reassess the presence of a pulse after 60 seconds of well-coordinated chest compressions and ventilations. Vascular access can be acquired by using umbilical vein. However, this is not something that we will generally do in our scope of practice. IV and IO access are more common in the pre-hospital setting. Pharmacological interventions are rarely needed, and if so, you would consider using epinephrine and fluids. Transport to the nearest facility to provide the next level of care once the newborn is stabilized as much as possible. This needs to be communicated to the parents. Do not be specific about survival statistics with the family or caregivers, and if you cannot answer questions, tell them you will put them in touch with those who can. Development of new techniques for newborn care has reduced mortality among high-risk newborns. It may be necessary to transfer critically ill newborns to a regional center to get needed treatment. Transport of a high-risk newborn should include the following steps. A physician at the referring hospital initiates a request for transport. Mode of transportation is chosen depending on distance, availability, and weather conditions, and the transport team is mobilized and equipment assembled.